This video will review oppositional defiant disorder and conduct disorder for the NBCOT exam. I covered antisocial personality disorder in adult mental health conditions, part 1, but these disruptive behavior disorders are not considered a personality disorder, although individuals may exhibit antisocial behaviors. So, the difference between the terminology and classifications in the DSM is between personality and behavior, but they share many similarities. After watching this video, especially if you're only watching this on YouTube, be sure to enroll in the free NBCOT exam prep course for the study guide and other great content that is also free to help you prepare for the NBCOT exam. The link will be in the description. I'm Jeff, the OT dude, and let's get functional. So what are the similarities and differences between oppositional defiant disorder and conduct disorder? Well, in both, children may be defiant and it may co-occur with other conditions such as, say, ADHD, mood disorders, anxiety, and depression. A child may have both ODD and conduct disorder with overlap in between. The DSM classifies ODD as a condition that involves recognizable and negative behavioral patterns that include an overall negative agitated mood. They may be quarrelsome or vengeful. With conduct disorder, there is a continual pattern of aggression towards others and rule-breaking behaviors. Examples of symptoms of ODD are children who, say, lose their temper, express anger, are argumentative, disobedient, or disruptive. With conduct disorder, keyword conduct, symptoms seem more severe in terms of social conduct and laws even. They may, say, bully, initiate fights, use a weapon to injure others or animals, such as animal cruelty. They may steal, be arsonists, destroy other property, breaking in, that kind of thing. So much more serious in terms of conduct and when it comes to the law. Here's an important point that will be helpful for you to distinguish between ODD from CD and kind of the differences between them. With ODD, it may precede the development of conduct disorder. So clients with ODD, especially if it's left like untreated, they may be a high risk for developing conduct disorder. So it's kind of like a progression, so to think of it. And if left unchecked even more, this persistence of these behaviors into adulthood actually may lead to a third thing, antisocial personality disorder. One thing to consider for these conditions are the differential diagnosis and comorbid conditions. So a lot of overlap with other conditions based on the symptoms. So it's not very easy to really distinguish. So these include ADHD, mood disorders, learning and developmental disabilities, adjustment disorders as in adjustment to disability, relational disorders, depression, anxiety, and substance abuse. As you can imagine, these behaviors can have a significant impact on the family and those around them too. The treatment team would include the client, such as the child, caregivers, teachers, educators, physicians, occupational therapists, and other professionals as needed. And here are some outcome measures I think that you can use that are also multidisciplinary too. Don't worry about memorizing these, but you should be familiar with them if provided on the NBCOT exam so that you can make a pretty good choice about whether to use it or not. And the research supports the use of the following: the short sensory profile, Iberg child behavior inventory, the aggression scale questionnaire, so keyword aggression, child behavior checklist, youth self-report, parent daily report, and the interview for antisocial behavior. Treatment for the disruptive behavior disorders can be approached from 3 different tiers, so to speak. One more broader is the universal, then there's targeted, and for some of the more troublesome kids intensive. The OTs, in terms of the process, can take a history, use the relevant assessments, and screen, observe, and assess basically for the degree of the functional impairments, such as in the occupations or environment for, say, school or other occupations such as social relationships. And with this, using a family-centered, as we have discussed before, approach is probably the best as it develops an individualized treatment plan for the client. Research for intervention supports the use of individual therapy, family therapy, parenting management training, also known as PMT, problem-solving training, conflict resolution, anger management, and improving social skills. And other approaches that may be helpful include reinforcing the positive behaviors, so behavioral theory, and practicing, say, stress and relaxation techniques, and doing things like yoga or mindfulness. And also what helps is providing structure, such as for the parents, so being family-centered again, right, when asked on the NBCOT exam. What also helps is to encourage the parent to enforce the rules consistently so that it's not confusing for the client, and also to develop a stable support system and refer to support groups as needed. Also, in terms of mental health, CBT may be effective, especially when the child is older, say, than the younger clients. Also, group CBT has been found to really help to decrease the peer-related aggressive behaviors, specifically in boys aged 6 to 12 years. Another is the multi-systemic therapy, which basically incorporates peer interventions, social interventions, and the context of the family and the school with individual interventions as well, and to help address the components of the problematic behaviors in the child in a holistic kind of sense. And therapy may be used in conjunction with other things such as medications as well, and this is quite common. A commonly used one, though you probably won't know the generic name, which is methylphenidate. It's also known as Ritalin brand name, and it's used also for ADHD actually, and this may be helpful in helping the client to manage their symptoms of, say, aggression. And another common one is Strattera. And other ones that are used are non-stimulants as well, like clonidine. Risperdal is an atypical antipsychotic you probably have studied, and that also has some pretty strong evidence for the treatment with the aggression, even though it's in the class of the atypical antipsychotics. In terms of typical antipsychotics, things like Haldol were shown to be inconsistent in managing aggression, so not so effective for its other use. Also, mood stabilizers like lithium were also found to be weak in terms of evidence, and there's also a lot of side effect concerns too. And so building a therapeutic relationship is also very important as it may help with the treatment and also with the child's engagement in their occupations. So strategies include like validating their feelings, setting collaborative goals, orienting the client to their roles, and involving them in the treatment process. Helps to establish your credibility and adapting your treatment really in response to the individual client-centered differences. You should also provide homework assignments as needed. And as mentioned, the parents should be consistent, right? So should the therapist in terms of everybody being on the same page so that when the client shifts in between different environments, it isn't as confusing for them. Studies have shown that it also helps to address bullying, the antisocial behavior, and considering and assessing the peer group influences. What also helps is to use timeout also in certain situations, of course, depending on the age, and deciding really which rules may be negotiable with the treatment team. In terms of positive reinforcement, providing praise with the reinforcement, and having also a backup plan as well in terms of what you should do. Address the caregiver in terms of their self-care and their burnout, and in terms of More creative things, groups like music programs, drumming, art therapy, and other media can also be helpful as well. So, here are some things to really not do and to avoid. The NBCOT may ask these types of questions, so it is good to consider this. How you interact with the clients and caregivers is one of these considerations. For parents, a short-term or those one-time therapies, such as like boot camps and tough love camps and other scare tactic camps, they're not as effective. So of course, to approach this topic with just the evidence and the information. Also avoid using threats, emotional responses in terms of how you respond, confrontation, responding quickly, bribing the child, and just having power struggles in general in between the two parties. To avoid escalation, you should avoid yelling, using sarcasm, or expressing your frustration as much as possible anyways. Well, what about negative reinforcement? Well, it has shown to be pretty ineffective in terms of this condition, as you all probably have learned in terms of behavioral theory and how positive reinforcement is better, such as using praise. And besides the communication skills and the problem solving skills, we should really address the occupation, right, as OTs. So one thing that may be useful are what's called videotape vignettes. And it sounds complicated, but we all have a smartphone these days. And with permission, having the parent tape basically what they do and using it as a teaching opportunity to improve the child-parent interaction has been shown to be pretty helpful in preventing problems in terms of occupations and barriers to it, such as self-care and socialization. And I would imagine also be helpful for other occupations too, such as school and leisure and IEDLs, like in the home environment as well. So now it's a good time to give a video a thumbs up if you found it helpful, and also check out the resources in the description for more. I know it was kind of a quicker version video, but definitely rewind and rewatch this as well and supplement it with other resources that are pretty helpful, such as from other study groups and even things you used in your class. This isn't a necessarily heavily tested topic, but it's good to review this one just in case. Thanks for watching and good luck studying.